to have this lecture today, and very fortunate to have Dr. HALASA to be available for questions and answers afterwards. Dr. HALASA, would you like to start?
Yeah, thank you very much for introduction. And yes, I would like to emphasize on things that we call them unmet medical needs and things that we need to increase the performance in our clinics. And especially in pain management, we recognize that there is a gap that's not been filled, which is understanding the central pain. And we see a lot of pain doctors, when they are managing pain, they focus on the location, the source of the pain, where the patient is referring to, and they do all this kind of injections. And the reality is that peripheral pain, where the doctors is focusing on injecting, it could be complicated by central pain. And so the pain is not anymore coming from that knee joint where you inject the PRP and steroid. Yes, you fix the peripheral pain, part of it, but you still did not fix the pain that is actually developed from that. And that's the reason the patient will come back to you and say, you know, I feel better, but not that complete better. I still have pain in my knee. And you did all those steroid injections and PRP, and possibly you thought about neuroma and you inject those and you burn them, but radiofrequency ablations, but still the patient is complaining from pain from that area. And so it could be neurogenic pain. And we will see that neurogenic pain, it could be also peripheral and central. So there is central neurogenic pain, and also there's peripheral neurogenic pain. And sometimes the peripheral and central neurogenic pain does not respond well to anti-inflammatory drugs and steroids. And that's the reason we need to think about this central pain as part of the pain condition of the patients and fix it. So what is a central pain? Is a neuropathic pain that happens when the central nervous system does not process this pain signal properly due to change in the neuroplastics of the brain, or brain neuroplasticity. And that's happening because of the chronic peripheral pain that evolved into chronic or neurogenic or neuroinflammatory process that leads to change in the brain neuroplasticity. Why peripheral pain is nociceptive pain that's not part of the central and caused by inflammation or injury. You know, osteoarthritis, inflammation, injury of the joint, or rheumatoid arthritis, which is autoimmune disease, or burning or fracture, all those injuries, inflammations, can cause what? Peripheral pain. So again, we will see that patient had osteoarthritis and they remove their joints. There's no more knee joint, for example, but they still have pain as it's coming from that prosthetic knee. Really, there's no joint there. So, you know, there is no peripheral inflammation, and you can argue that's possible. You may have what we call the neuroma, and you burn those neuroma radiofrequency ablation, and still the patient is saying, I have a pain is coming from the knee. So it seems like the inflammation is not anymore in the knee, it's in the spinal cord and the brain. And that's what we're going to talk about, how chronic inflammation, peripheral, evolve into central inflammation or central pain or central neurogenic inflammation. And we're going to talk about the neuroplastic changes that happen in the spinal cord due to the inflammation. So about 20% of the patient with osteoarthritis who had their knee or hip replaced continue to have chronic pain. The pain has likely become centralized, so it's not longer caused by the inflammation of the knee itself. Okay, so again, the reason I am talking about complex regional pain syndrome, because it's a good model that shows how the peripheral pain evolve into central pain, how peripheral inflammation evolve into central neuroinflammation or neurogenic inflammation. And then the neurogenic inflammation, the central one, can evolve into peripheral neurogenic inflammation. So you have this vicious circle in the complex regional pain syndrome. But again, this can be also happen in any chronic inflammatory disease out there. Rheumatoid arthritis, psoriasis, ulcerative colitis, Crohn's disease, name it. Neurogenic bladder, migraine, fibromyalgia, they can be complicated by neurogenic inflammation and centralized pain. So let's say now we want to look at the pathway, take a look at the pathway of the pain, because understanding the pain pathways and the mechanism of pain and the neuroanatomy of the pain and the neurophysiology of the pain and the pathophysiology of the pain will give us better understanding of how to manage pain. So people will think, you know, this is more of academic. No, it's not. It's clinical. Because if we don't understand the mechanism of action, you cannot put together a protocol to manage that disease. So mechanism of action is very important. And you're going to see that when we elaborate more in those coming slides. So let's say, you know, I accidentally torched my finger with the candle, and as you see, the pain will go through C fibers to the spinal cord, right? And then up to the thalamus, to the spinothalamic tract. And then when it reaches the thalamus, that's where we feel the pain, but we don't know how severe it is until it gets into the amygdala, as you see the yellow color there. Amygdala is the center where we process the pain, and also we will be able to identify the severity of the pain. So if you damage the amygdala, what will happen to those patients? If you poke them with a needle, they may feel the pain as a touch or something there, but they don't react to it. You don't see any reactions of it. They don't cry or pull their hands, or it's just something, it's there. They feel it as a sensation because it's still the hypothalamus is working, but they cannot understand it, what it is. They cannot evaluate the severity of it. You ask them how severe the pain there, and say, well, I just feel something there, but I don't know what it is. And even if you poke them more and more, they don't have the reaction of pain. And there are some conditions there of people who have this problem. I don't know if you hear about it in the news, where an old lady, she doesn't feel the pain. Well, and she doesn't react to it. Is it a good thing? No, I think pain is part of our life. And I think pain is something that it just gives us the feeling that we exist. So what happened is that, as we know, this amygdala is the center for processing the pain, and it will send signals to the hypothalamus, and the hypothalamus will give you that response, the fight-flight reaction, right? Increasing your heart rate, and the breathing will be more faster, you breathe faster. So it gives you that fight-fight reactions, so increasing the sympathetic tone. But also, we need to localize the pain, so the signals will send from thalamus to the primary somatosensory cortex, and that's where the patient can say, well, I have a pain, it's coming from my hand. No, it's being localized. But in order to